commonly mistaken for pediatrics, but with podiatry, we prevent and diagnose and treat conditions of the foot and ankle. Training after college is a 4-year podiatric medical school, followed by 3 years of clinical and surgical residency training, then an optional 1-year fellowship for those who want to do more advanced research or want to get more hands-on experience with surgery. One of the owners of the company, he trains fellows for additional reconstructive efforts and peripheral nerve surgery as well. I did my residency training at the Cleveland Clinic, and Mercy Health was based all over Northeast Ohio. And now I'm able to work in the city that I grew up in. So just a kind of an overview of what we're going to cover today: disorders of the nails and skin, soft tissue conditions, structural deformities, bone and joint conditions, and also my personal favorite, trauma. So ingrown toenails. As we all know, they're curved nail borders that grow into the skin and the sides of the nail. They are often associated with pain, redness, swelling, and warmth. And for most individuals, unfortunately, they become infected. So what can cause these pesky ingrown toenails? A lot of times they can be due to improper trimming, as you can see from the bottom right-hand depiction of what we deem as improper trimming. Trauma to the nail: if you drop something on the toe, or you're grabbing a drink of water in the middle of the night and kicking a nightstand, can lead to trauma to the nail. Improperly sized footwear: we see that a lot with our growing young athletes, as their football cleats or volleyball shoes tend to be worn from last year and tend to be a bit on the tighter side, which can create these pressures to the medial and lateral nail folds. Hereditary conditions can make you a little bit more prone to having ingrown toenails. Some individuals' nails don't grow as flatly as others and can have this more of a staple-like appearance. Nail conditions such as onychomycosis or nail fungus can lead to ingrowing toenails as well. So another depiction on the top right showing ill-fitting shoes. As you can see how that can be a problem. Home care. Home care may be a safe treatment for those. However, there's a vast majority of patients that should not perform home care. An obvious infection, associated diabetes, nerve damage in the foot, or poor circulation, please do not try to do anything at home. But if you don't fall in that category, you can try foot soaks with warm Epsom salts water. Gentle massages along the side of the nail fold would help relieve some pressure. And avoid bathroom surgery, please. Trying to take care of this at home by poking and prodding just tends to lead to infection, which ends up making the procedure, all that much more difficult, and condition all that much more painful. So what do we do for this? As a physician, we can do minor surgical procedures may be performed. Initially, we remove the offending nail border. That is done in the office under local anesthesia. For repeat offenders, if you will, what we'll do is remove the nail root in the office by chemical cauterization, and for some that are a little bit more recalcitrant to chemical or office debridement or excision, I should say, we take them to the operating room occasionally to help out in that sense. Possible antibiotics for infection. I'm not very keen on leading out with antibiotics for ingrowing nails, as you want to treat the underlying deformity as opposed to just treating with antibiotics. I'm of the camp that we tend to over treat things with antibiotics without eliminating the root cause. So typically we need to remove that offending nail plate plus or minus giving the antibiotics, and not the other way around. Moving on to plantar warts. They typically are growths on the bottom of the skin. For us, obviously on the bottom of the foot, caused by the human papillomavirus. They may be solitary, or they can also present in clusters, and they are more commonly seen in children, adolescents, and the elderly patients. Symptoms: they tend to present as a callus with these tiny black dots on the surface. They typically present with pain associated with walking and standing over these the bottom aspect of the foot. Treatment-wise, our literature states that they often clear up on their own. About 50% of the time, these warts will clear up on their own. There's a variety of treatment options, including chemical variants and freezing. A lot of times, it's also it requires several treatments, weekly treatments in the office. If they do become unresponsive to treatment, we may perform a biopsy and/or surgical or laser removal, which again can be done in the office or in the operating room. Some of these folk remedies that I hear about, duct tape and such, they haven't really been found to proven to work, as they tend to cause more pain than actually relieve any pain and symptoms. So some conditions of the soft tissue. We'll start off by talking about ganglion cysts. They are fluid-filled sacs that often originate from tendons or joints. They often occur along the top of the foot, and they vary in size. Some actually get larger, some get smaller, some stay about the same. They may also disappear and reoccur. So some of the symptoms include, as you could see, a lot of times you can see a visible lump, and with some individuals, that's the only symptom. So, they come in and say, "Hey, doc, I have this bump on the top of my foot. What do you think about it? Doesn't really bother me at all." But unfortunately, there are others who present with tingling and burning, especially if the cyst is located over one of the dorsal nerves. It also may create dull aches and pains, and that may indicate that the cyst is pressing against a tendon or a joint. And as you would imagine on the picture on the right-hand side, putting your foot into a shoe can make this a little bit more difficult. So a little bit more talk about how we treat these ganglion cysts. Sometimes, again, if you're a patient that presents with no real pain, we'll just monitor it and see if it'll get larger or see if it gets smaller. For those who have a little bit more irritation from rubbing, we'll do shoe modifications and padding. For those who are really adamant about having the cyst removed, there's aspirations and injections that we can do in the office. And surgically, if the cyst creates more of a problem, we can remove them in the operating room. Next, we'll move on to something called a Morton's neuroma. It's a thickening of the nerve tissue between the bones of the ball of the foot, located along the forefoot, caused by compression and irritation of the nerve. It's usually resulting from pointed toe boxes, narrow shoes, high-heeled shoes. Certain types of foot types will also cause these Morton neuromas. Some of these people with these higher arched feet can develop these neuromas, and activities as well, more in the line of repetitive irritation to the ball of the foot, running, court sports that you can think of, basketball, squash, and things like that may cause these injuries with this repetitive, up and down motion. Some symptoms of Morton's neuroma: you can get some localized tingling, burning, pain, and numbness in the ball of the foot, or actually radiating to certain toes. And for most patients, they come in and they say, "Hey, doc, I know I didn't step on anything, but it feels like I'm walking on a marble, feels like I'm walking on a stone, or it feels like my sock is rolled up or bunched up inside of my shoe." That's usually a sign that you may be suffering from Morton's neuroma. Of course, typically the symptoms may occur occasionally once you remove the deforming force in terms of the ill-fitting shoes. You can just massage the area or laying off these high-impact aerobic activities, and it'll go away. However, for some unfortunate individuals, they may progress and worsen, and these symptoms above may persist for several days or weeks, even after, again, removing the shoes and massaging and stopping some of these activities. And for even a smaller select individuals, they may get some associated nerve damage, as it may become permanently damaged, and the symptoms may persist. So a couple of non-surgical treatment options: padding, shoe modifications, icing. We can offer shoe inserts, whether they be custom or over the counter, activity modifications, oral medications, and injectable therapy. Surgical treatment for Morton's neuroma ranges on the severity. Usually we can do excision of the neuroma And we can also do RFAs, radio frequency ablation, where we essentially superheat the nerve and destroy it. Well known to most people is plantar fasciitis, is probably the most common soft tissue ailment that we see in our office. Plantar fasciitis is an inflammation of the band of tissue that extends from the heel to the toes. Fascia first becomes irritated and then it can become inflamed. And it's the most common cause of heel pain that we see in our office in a non-trauma setting. The depiction on the right-hand side of that plantar fascial ligament, and a lot of patients will have pain right where the ligament inserts into the calcaneus, or that heel bone. So most common cause, again, debatable, but foot structures, overly flat or high arch feet can cause plantar fasciitis. There's some other contributing factors as well: walking on hard surfaces, flat surfaces, tight calf muscles, obesity, and overuse. Symptoms of plantar fasciitis included, but are not limited to, pain to the bottom of the heel and sometimes traveling along the arch. Pain that's usually worse upon rising. For those individuals who sit for a short period of time and then stand back up, that's usually indicative of plantar fasciitis, or pain with the first few steps in the morning, and then it kind of gets a little bit better from there. But there's some individuals where it doesn't get better throughout the day. Pain that increases over a period of months as well, and you can get some associated swelling to the bottom of the foot as well, or bottom of the heel. Some brief treatment options for plantar fasciitis. Stretching for me is number one, number two, and number three things that kind of help get this better for you. Stretching exercises really help. Always wear shoes with cushion and support. And we could talk a little bit more about that in the office. Avoiding barefoot and flip-flops as much as possible as well. Ice massages as well, I find helpful. Freezing a frozen water bottle and passing it underneath the heel tends to help. And limiting these aggravating activities, and oral medications as well. A little quip about, again, I'm big on the stretching exercises for plantar fasciitis. Keeping a belt or towel bedside, doing towel stretches and wall stretches for 30 seconds. Wall stretch, also known as a runner stretch. Always stretch prior to activities. Again, it depends on what camp you fall within. Some people just don't like this notion of dry stretching, if you will. But I always find that stretching kind of keeps you away from doctors' offices and the emergency departments for the most part. Importantly, should stretch even after heel pain improves. It's just something that should be part of your routine. Just because the symptoms have gone away, it does take a while for you to get to that period. It's not something that should go away. The stretching should not go away, after the symptoms have resolved themselves. Some of the treatments that we perform for patients: padding, taping, strapping, orthotic devices, whether they be custom or over the counter. We also do oral and injectable steroids, depending on the patient, non-diabetics and such. Removable walking casts for individuals that are in an extreme amount of pain, and walking at all is pretty difficult. So we like to put them in these removable walking casts, and sometimes we'll even put them in crutches as well. Night splints, it's a bit of a misnomer with the name, but it's basically a device that helps you stretch. You never wear it, throughout the night. At least, I never have my patients do, but it's just something that's worn, for a good, 10, 15, 20 minutes at a time, and just gives you some reproducible stretching every single day. Physical therapy we use quite a bit as well to help you out. And these rare cases, I would say probably about 5% of my patients, if they do not get better with the above treatment, we do take them to surgery as well. So next, we'll talk about disorders of the Achilles tendon. I'll talk about Achilles tendonitis versus Achilles tendinosis. Achilles tendonitis is an inflammation of the tendon. It's typically short-lived. Tendinosis is associated with more degenerative changes within the tendon and may develop these micro tears. Good little illustration along the bottom. These tend to be caused by overuse syndrome. Obviously, the late great Kobe Bryant ruptured his Achilles tendon. I'm a victim of rupturing my Achilles tendon as well. Sudden increase of repetitive activities can cause these type of injuries, and they're usually associated with the weekend warriors. Individuals who don't necessarily train or stretch throughout the week, and then they decide to go a weekend long playing basketball or pick up touch football or whatever the case may be. They tend to develop these injuries from that. Athletes do get it. Even high level athletes will develop Achilles tendon issues, even if they have the best stretching programs in the world. You're not immune from injury. Individuals who work on their feet all day, and individuals with a pronated flat foot type pes planus views tend to have these injuries as well. Symptoms: pain, achy, stiffness, soreness, and tenderness anywhere along the tendon itself. May get worse when getting out of bed or with periods of rest. Tenderness or pain when squeezed on either side of the tendon as well. That's a sign that you may have some Achilles tendonitis or tendinosis. The tendon may become enlarged with some nodules along this area, what we call the watershed region, right where the Achilles tendon inserts into the calcaneus or into the heel bone. Symptoms of an Achilles tendon rupture include sudden severe pain to the back of the leg, difficulty putting weight on the back of the foot or walking normally. Some non-surgical treatments: immobilization, icing, oral medication, obviously to help with pain and inflammation. Orthotics, again, whether they be over the counter or custom. Night splints, a little less aggressively than what we do for plantar fasciitis, but the stretching does help. And again, this is different if we're talking about Achilles tendonitis and tendinosis versus Achilles tendon rupture. Obviously, those have their own individual treatment plans. And physical therapy, again, I find that physical therapy is a great adjunct to some of these injuries. Again, whether they range from the Achilles tendonitis all the way up to the severity of Achilles tendon ruptures, we do find that physical therapy does help in an extreme amount. And surgical treatment options, again, for reserved for those individuals who have failed conservative therapy. And there are various repair techniques. I can do an entire other lecture on that. It all depends on the MRI findings, how severe the rupture is, and how much distance there is within that gap. It all depends. And here's a depiction of a bit of an antiquated technique, but some individuals do it where we essentially just suture the tendon up and down and then do a primary end-to-end repair. But hopefully we never have to have this discussion. So how do you prevent these type of Achilles injuries from returning? Especially with Achilles tendonitis, you can, again, warm up muscles before you exercise, avoid sudden increases in your activity levels and exercise regimens. Again, try to avoid these weekend warriors. Try not to thrust yourself into a basketball tournament or anything like that if you haven't played in a while. Just kind of keep your activity levels at an even keel until you get up into a certain level. Wear appropriate and supportive athletic shoes, and avoid, if you can, running on hard, uneven surfaces. Another dysfunction that we see as well is called the posterior tibial tendon dysfunction. It is a pain and eventual flattening of the foot due to changes within this posterior tibial tendon. Another name for PTTD is adult acquired flat foot deformity. And we have individuals who, kind of say, "Hey doc, I've noticed I'm having some pain along the inside of my ankle. My foot is beginning progressively flatter on the one side or on both sides." And again, this is generally due to this posterior tibial tendon dysfunction. Causes is usually an overuse type of injury, and it's a progressive deformity. Based on the stages, you can get this progressive deformity that can lead to arthritic changes into the subtalar joint and into the ankle joint as well. So again, some of the most common locations of pain is along the course of the posterior tibial tendon. Obviously, as you can see right there on the yellow line, which travels along the back and then on the inside of the foot and ankle. So the toe that you see is the big toe there. So a lot of this pain is along the inside of the ankle. And that's the picture. I know it's not all that clear there, but that's looking along the inside of the ankle. So what are some symptoms? Again, pain, swelling, can be on the outside of the foot, but also more commonly along the inside of the foot. As you can see a picture from there, you can see a progressive collapse, the medial longitudinal arch, or you can see again a collapse of the arch, revealing this more flat foot. The course, initially pain along the inside of the foot and ankle. Again, as I said, maybe warm, hot, swollen. You'll start to see that progressive flattening. The foot turns outward and the ankle starts to roll in. Again, if you're not used to seeing these, whenever you take a picture of someone from behind, you should not be able to see all their toes when standing directly behind someone if positioned correctly. As the arch flattens out over time, the pain shifts to the outside of the foot, something we call subfibular impingement. And again, you can start developing some arthritic changes to the hind foot and ankle. So non-surgical treatments, hopefully if caught early on, we have, again, orthotics, whether they be custom or over the counter, immobilization, physical therapy, medications, oral steroids, and other adjuvants that we can use as well, and shoe modifications. Surgical treatments for individuals who have failed conservative treatment, or for individuals who show up with some pretty significant arthritic changes. We can do a repair of the associated tendons and soft tissues. And what we do is we try to help realign the foot underneath the leg and address any arthritic changes that you may have. Just an example of an X-ray of a post-op patient that had to undergo surgery in order to fix their flat foot deformity. We'll talk about structural deformities. Bunion, or also known as a Hallux deformity, or I'm sorry, Hallux valgus deformity, appears as a bony bump along the inside of the great toe joint, and it reflects a change in foot structures. This is also a progressive disorder. Starts with the big toe leaning towards the small toes, eventually a formation of the bump along the side of the big toe. So the causes of bunions, again, it's a kind of hotly debated, but inherited faulty mechanic structures of the foot. Certain foot types are prone to bunions. Those are associated with more of a flat foot deformity can be more prone to bunions. Shoes, for the most part, they don't cause bunions, but they can make the deformity progress faster. Think about that picture that we saw with the ingrown toenails, where you have these ill-fitting shoes, these more narrow toe boxes, pointy-toed, high-heel shoes, and things like that. They may not necessarily cause the bunions, but they will make the deformities progress much faster than individuals who don't wear them. So what are some symptoms of Hallux valgus? You get pain and soreness in the area, inflammation, redness, a burning sensation as it irritates the nerve that runs alongside the bump, numbness, again, associated with that nerve. And it's also often worse with tight shoes, high-heeled shoes, or prolonged standing or with activity. Diagnosis, for most individuals, it's pretty obvious that they usually write it in their complaint before they even come see me, that they have this big bump along the side of their foot. But with clinical exams, we can help them diagnose it with them, and then radiographs help us determine the severity and kind of helps us a little bit more in our surgical planning. Non-surgical treatments for Hallux valgus deformities, changes in shoe gear, padding, modify activities, medications, icing, injections, shoe inserts, and orthotics, again, whether they be custom or over the counter. And as a note, these improve the symptoms, but they do not correct the deformity. I always like to tell my patients, when you come in with a bunion, the only way to fix it is with surgery. But just because you have a bunion doesn't necessarily you need surgery. We usually reserve that for individuals who are in a good amount of pain and it's affecting their daily quality of life, and it's inhibiting their daily activities. So, we help them out with that. These things will help make the symptoms improve, if you will. But again, you'll always have the bunion unless you have surgery, but we guide you to exhaust all possible conservative options before discussing surgical treatment. Again, the goal of surgical treatment with bunion deformities is reduction of pain and deformity, with the emphasis on of pain, because there is, associated risks and problems that can come with surgery. So we want to try to attack both those items. There's a variety of surgical procedures, again, that all depends on what the clinical examination is, what the radiographic findings are, and what are some other associated deformities that you may have. Again, like we talked about, a flat foot may cause the bunion to form. So if you don't address the flat foot, you're essentially just putting a Band-Aid on and having this thing essentially come back. So we can remove the bump, the correct the structural deformities, and correct associated soft tissue changes. Again, I know very vague, but each bunion presents a little bit differently. So it's kind of on an individual basis. Recovery, again, all depends on what procedures we do. We have some where we can walk you pretty immediately after surgery, and there's a couple of things that we can do that necessitate you being off the foot for a long period of time. So again, on a case-by-case basis. The Tailor's bunion is just a bunion on the opposite side of the foot. It's usually a bony prominence on the lateral aspect at the base of the fifth toe. The causes, again, changes in bony structures, and it could lead to some spurring as well. Symptoms, as you may think about, it's a pretty on par with the bunion deformity. Redness, swelling, pain at the site of prominence, and often worse with shoes that rub against it, because again, it's right on the lateral aspect of the foot, just like the bunion was along the medial aspect of the foot. Again, same with the bunion deformity. It's all diagnosed with clinical exam and X-rays. So shoe modifications, again, padding, strapping, oral medications, icing, injectable therapy, and orthotics do help with Tailor's bunion, along with bunions as well. Procedures, again, you can read that on the screen. Very similar to the bunion protocol as well. All depends on what the what the X-rays show. And again, that's the associated recovery just is all based on the procedures performed. Hammer toe deformities, kind of this clawing or this bending deformities of the toe. They usually start off mild and flexible and may become rigid over time. I would say about 50% of the patients that we see come in at whether it's a little bit more mild, a little bit more flexible, where we have more options to treat conservatively. Once these deformities turn into a more rigid nature, it makes it a little bit more difficult to address conservatively. Causes tend to be from a muscle tendon imbalances, usually associated with your foot structure, and previous trauma can cause hammer toe deformities as well. So symptoms, obviously just visible contraction of the toe with associated pain and irritation of the toe when wearing shoes. You'll get some inflammation and redness and burning sensation where these areas are clawing up and rubbing along the shoes. You can also get some pain at the ball of the foot as well, as it kind of alters the mechanics and puts these metatarsal heads, or again, the bones that connect the toes to the foot, can make them a little bit more prominent with these hammer toe deformities. You can get corns and calluses can develop over top of the surfaces of the toe, at the tips of the toe, or the ball of the foot, or even between the two toes. So obviously, as you would imagine, that can be a bit of a nuisance, and actually for some of our diabetic patients lead to some sores and subsequent amputations. So again, non-surgical treatment, this is usually resolved for individuals with the more mild deformities, some of these more reducible deformities. We can do some padding of the corns and calluses. Not a big fan of these over-the-counter pads that contain acid. The acids tend to burn everything centrally, which can include intact skin. So unless your callus is the exact diameter of the pad containing the acid, you're asking for more problems, and it can actually make things a lot worse. Changes in shoe gear, again, trying to avoid shoes that rub along the top that create the callus. Unfortunately, we don't live in in Florida or some of these warmer weathers where we can get away with wearing flip flops and things like that. So in shoe gear, it can make it a little bit more irritating. Orthotic devices, again, custom or over the counter, splinting, strapping, injections, and medications as well can help. Surgical treatment, as you would imagine, it all depends on the individual deformity, where the cora is, or where the apex of the deformity is. We also do some soft tissue work as well. A lot of times, again, we can do bony work versus soft tissue work, depending on how mild or moderate the deformity is. A lot of times, we can also do them in conjunction with other surgeries as well. You know, sometimes, as you can see on the screen, some individuals with bunions will have hammer toe deformities as well. So we usually correct those all at the same time. And surgery is not always performed in the operating room, believe it or not. We also do in-office procedures where we can actually release some of these deforming forces inside the office in a very minimally invasive way and get you walking out the same day where you don't need anesthesia at all. Obviously, for the more involved cases, we'll take you to the operating room and take care of you from there. And the recovery, it all varies. If we're doing other associated bunion work or Tailor's bunion work or flat foot work, you tend to be off your foot a little bit more. But traditionally, when we do fix these hammer toes, you are walking same day. There's a lot of new technology out there that helps speeds along the process. But again, we like to reserve surgery for those who are in constant pain and that are looking and have failed conservative therapy. So conditions of bone and joint. Osteoarthritis, it exists everywhere, even in the foot and ankle. But for us, when we see it, it's typically located in the great toe, which is a condition called hallux limitus or hallux rigidus. We can also see it in the midfoot. And as we talked about with end stage flat foot deformities, we can also see some breakdown of the cartilage or osteoarthritis in the hindfoot and the ankle as well. It can be caused from, as you know, with osteoarthritis is associated with the wear and tear disease. Can also be post-traumatic. We see this a lot. We'll get into it when we talk about trauma. But some of our heel fractures and ankle fractures, we can get individuals who unfortunately develop post-traumatic ankle arthritis and abnormal foot mechanics. Again, as I stated, with the flat feet, whether we adult acquired or not, we can see these individuals who just develop these unfortunate osteoarthritis. And high arches or pes cavus individuals, we also can see that as well. Symptoms of osteoarthritis in the foot and ankle associated with pain and stiffness in the joint, swelling in or around the joint as well, difficulty walking. A lot of patients will come in and say, "Hey doc, I have this bump that's on the top of my foot. It feels like bone, and there's pain associated with it." Sometimes individuals will get pain with pressures in shoes because they're getting a lot of rubbing and they need help and some advice on how to offload those areas. And they can get blisters, calluses, and adventitial type of bursitis that can develop as well. Again, we always like to lead with the non-surgical approaches, oral medications, Tylenol, and anti-inflammatories and such. Again, orthotic devices, whether they be custom versus over the counter. Bracing options help as well, immobilization, padding. Sometimes we'll draw corticosteroid injections into the area in the OR or in the office. And again, physical therapy can be of some help, with osteoarthritis as well. Some individuals, for those who fail the conservative measures and want to talk a little bit more about surgical ways to address it, the goal, like we talked about with some of these other procedures, is to reduce pain and improve function. Again, reducing the pain with it is our biggest kind of goal in all this. And there's a million different procedures you can do, and it all depends on the joint itself. Sometimes we just go in there and resect the bony prominence. That all depends on your age and activity level. We can also fuse the joint as well to I guess, finish up the process of what the body is trying to accomplish with this wear and tear of the cartilage. We can go in there and complete the job, get rid of the rest of that anti-fusion material of cartilage, and put plates and screws to hold everything in together. And there's joint replacements as well. Our practice is associated, one of the few places in the area that does total ankle replacements as well. So we can do it all for you. Stress fractures. Again, these are small hairline breaks in the bone, incomplete breaks in the bone themselves, a little hard to pick up on x-rays. The causes can be from a sudden increase in activity, overtraining and overuse, improper techniques, changes in surfaces, improper equipment, poor bone quality. We usually, see these a lot with postmenopausal women with vitamin D deficiencies. As you can imagine, Northeast Ohio is wrought with individuals with low vitamin D levels, due to our lack of natural sunlight. So we do see our fair share of stress fractures and foot deformities. And high arches and low arches as well can put abnormal stresses and strains along the foot and can cause some of these issues as well. Symptoms of a stress fracture: pain that worsens with weight-bearing activity, pain that diminishes with rest, and that can intensify with even just normal activities of just standing and walking. Swelling on the top of the foot or near the heel. I guess, again, it all depends on where the stress fracture is, and it can be pretty tender at the site of the fracture. And sometimes you can see bruising or redness depending on the stage or how early or how late we catch the stress fracture. So some non-surgical treatments, we call it the RICE therapy: rest, ice, compression, and elevation. We usually put you in some sort of protective footwear, removable cast, the surgical shoe or stiff-soled shoes. For individuals who really can't tolerate putting any weight down on it, sometimes we'll put you in a short leg cast and get you off of it for a short period of time, and modifying the activities as well. Surgical for stress fractures, sometimes we'll put hardware to hold the two bones into place, or two fragments of bone into place, and prevent the deformity from getting worse. Recovery, again, kind of arbitrary, but 6 to 8 weeks, that's usually the guideline in terms of how long it takes bones to heal themselves. Not necessarily that you'll be off of it for 6 to 8 weeks, but that's the general rule of thumb when it comes to how long it takes for bones to heal themselves. And then more importantly is a gradual return to activities. A lot of times we'll work with your primary care doctor to more medically optimize you, if you will, getting your vitamin D levels up, having a good protein diet as well. And, if there was a way we could get some more natural sunlight, that would be awesome. But, there's other ways that we can try to help not make this a recurrent problem, which is what we see in some unfortunate individuals. Trauma. So I'll start off with talking about ankle sprains. Obviously, as an ankle sprain is an injury to one or more ligaments to the ankle. Can be along the inside of the ankle, but more commonly we see it with issues with the lateral ankle ligaments. And you can stretch them; they can be partially torn, or they can be completely torn. And this often is as a result from a fall, a sudden twist, or a blow that forces the ankle out of position from its normal position. Falling down the stairs, we see that quite a bit with individuals, with the icy weather and things like that, and a lot of sports injuries as well. So we all know what an ankle sprain symptoms are, but I'll just go over it for completeness sake: pain, swelling, bruising, difficulty walking, and stiffness in the ankle joint. So back to the RICE method for non-surgical approaches for ankle sprains. The RICE, ice, compression, and elevation. Bracing also helps. Early physical therapy. I'm a big proponent of getting my patients into physical therapy as soon as possible for these injuries, and oral medications to help reduce the pain and inflammation as well. And for the unfortunate few individuals who do not do better after non-surgical approaches, because again, literature states that the ankle sprains typically will heal themselves within 3 months. An ankle sprain that lingers around for a little more than 3 months, we would typically get an MRI and then do a direct repair of the ligament, cartilage, and or injured structures. A bit of a vague statement, but again, these patients tend to present in different ways. It all depends on what your initial injury was and mechanism of action. Ankle sprains can take anywhere, between a few days to more than 8 weeks, depending on severity of sprains. And again, they typically have a good outcome. But what brings patients into our office for surgical consultations are improper rehab and severe pain. Individuals that have this chronic ankle instability, if you ever feel that your ankle is always going to give out on you, or if you find yourself rolling your ankle more often than not, excuse me, it's best that you come in and see us and evaluate this, because we may still be able to exhaust some conservative methods, and we can talk to you about some new advances that we have with chronic ankle instability that really helps. Foot and ankle fractures, to kind of round out the talk. These are partial or complete breaks in the bone. They can range, again, from small pieces of bone that are pulled off during an injury to some pretty severe shattering type of breaks that we see as well. These are often a result, again, from twisting injuries, direct traumas, falls. We see a lot of people winterizing their homes and falling off of ladders, a lot of ATV accidents, snowmobile accidents, individuals just slipping and falling on ice. And this is our ankle fracture season, where we've been pretty busy in that sense. And these are some of these high trauma areas. I think the top right, I believe, is an X-ray similar to an individual that I saw from a motocross incident, where he came down and got his foot caught in the pegs. And on the top left is a pretty standard ankle fracture, and again, that we see fairly common. Bottom, these heel fractures are usually a result of a fall, pretty significant fall from height. Although we had individuals who have fallen from shorter distances and still have fractured their heel. But all things that need to be addressed surgically, and they need to be addressed by foot and ankle surgeons who do this on a routine basis, which is what you'll get with us at our institution. Again, a little bit more about foot and ankle fractures. Pain at the site of the fracture. You can hear a pop or a snap. Significant swelling may occur. You may get some blistering over the site, depending on how high the energy, if you will, of the fracture is. You'll get some associated bruising and inability to walk, but that's not always true. We get some individuals, for whatever reason, will come in and their foot looks pretty bad, but they're able to walk on it. We see these X-rays, and there's a bunch of pieces and parts all over the place that need to be addressed. So we immediately get them in a cast and prep them for surgery within the next week or so. Protruding bone, obviously that's a medical emergency that has to go to the operating room within a few hours. Needs immediate attention. That would usually is a direct trip via ambulance to the hospital. Diagnosis for these foot and ankle fractures may require multiple types of imaging. We always start with X-rays, and then we can work our way up from CT and MRI, depending if I see you in an emergency setting or in the office setting as well. And that's to assess the severity and prevent undertreating. So non-surgical treatment, again, that's usually reserved for individuals who have a little bit more, I guess, these fractures are a little bit more well aligned, that don't require surgery. But the RICE therapy, rest, ice, compression, and elevation, sometimes will immobilize you in a cast for a short period of time, put you in a splint or a boot, and obviously offer medications to help relieve the pain. Surgically, again, these are reserved for individuals for more unstable, shattered, poorly aligned, and open fractures. For some individuals, unfortunately, they may go to the operating room right away, or we'll wait for the swelling to reduce. So here's some examples of some of the internal fixation that we have performed, or examples of internal fixation that we have performed for heel fractures, fifth metatarsal fractures, and then ankle fractures as well. Again, bones typically take about 6 to 8 weeks to heal themselves. We usually see you pretty regularly. For me, I like to see you on a weekly basis or bi-monthly basis to assess, soft tissue swelling, to take sutures or staples out, and to get serial X-rays to make sure everything's going okay. And we do our best in the operating room to prevent, osteoarthritis, try to realign all articular surfaces back together to kind of help you out and get you along, because some individuals may unfortunately develop chronic pain there afterwards. Again, long-term complications, fractures that involve the joint will often lead to post-traumatic ankle arthritis, and there are non-surgical and surgical treatment options that we can walk with you as well. So again, just to kind of thank you guys all for listening and taking time out of your day. Again, I'm Dr. Andy Orta. I'm located at the Foot and Ankle Specialist of Ohio. These are the locations that I currently go to. Our Mentor office, right on the corner of 615 and 20, 7482 Center Street. And then Chardon as well. We're in the Maple Leaf Plaza. Our phone number, so you can call and get an appointment with us. And then there is our website again, www.fasohio.com. Thank you guys for listening.